So people are still standing, but the room is quieting down. So I'll get going on my less important introductory remarks so we can have as much time for the panelists. So, as we go through, this intellectual arc of Bob's career, we come to the point of population health and the research and contribution that he's made there, and Bob very nicely framed that in his remarks this morning in terms of really the intellectual outflowing and impact that the research, particularly out of the Canadian Institute for Advanced Research in the late 1980s and 1990s, very much created a new discipline in Canada with respect to population health research, particularly with the book Why Some People Are Healthy and Others Not, which was seminal at the time and very relevant today. And I know a couple of the panelists today, Michael and John, played a contemporaneous role with Bob in that. And we also have Jeannie, whose work very much follows from that. So we're very fortunate to have, I think, three of the very sort of top minds in Canada and internationally with respect to population health to talk about the impact of this research field. The structure of the talk is a little bit different than what's in your agenda. It'll be starting with Michael Wolfson, then going to John Frank and Jeannie Cheveler. And unlike the other talks, we will actually be doing all three presentations, one after the other, so no questions. And then we will actually have 30 minutes for a panel discussion. So without further ado, I will leave you to read the speakers' bios in the conference materials. I'd like to welcome Michael Wolfson to the podium. Thank you, Michael.
Thank you very much, and it's a tremendous pleasure to have the opportunity to talk at this session, in part to celebrate Bob and all the wonderful research that he's done, and to share with all of you actually some stuff that I've been doing more recently that follows on and perhaps is a bit inspired by this. Let me acknowledge my co-author, Jeff Rowe, and CFI for giving us some money to get this going. Mine is going to be a rather more techie thing, and there's more stuff than I could possibly fit into 20 minutes, so some of it might be a bit blurry, but hopefully if you don't get all the words, you'll get the general theme of the music. Let me start with a few quotes or points from Bob himself, and we're switching gears here from health services to population health. And one of the things that Bob and I have discussed many times over the years is as a major failing of orthodox or mainstream economics is its failure to deal with population heterogeneity. And so here's, the only things only begin to get interesting, Bob said, when you take account of the heterogeneity of these individuals, a bit about inequalities, and then another point that he makes, which is go find out. Check what the data say, look at the real world. Now, a brief digression. The only time I know Bob to have failed to get part of a research grant was when he and a couple of the other characters put in $60 for chocolate. And the rest of the grant was funded. So, Bob, you've got to, I'll tell you that there's 4 scrumptious chocolate things on the screen right now. I couldn't resist. I'm a chocoholic too, so we share that affliction. So what I want to do is talk a bit about disjoint approaches to talking about health inequalities, and the idea is that some health inequalities may not be unjust. If some people get hit by lightning and others don't, that's not necessarily of moral consequence. But if the rich people live longer than the poor people, that is widely considered to be unjust. And I discovered as I got into this that there's a literature in moral philosophy where the focus is, in order to classify something as unjust, we need to know what its source was. If its source was unjust, then that kind of inequality is unjust. If the source was not unjust or not morally reprehensible, then so be it. but they never did any data stuff. Meanwhile, the empirical folks, they look at a gradient and they say that's unjust, but they don't bother to dissect, by and large, what are the sources of the inequality. So I'm going to try the outrageous task of bringing these two strands together. And some of you who know me will realize that I've spent an awful lot of time building things called microsimulation models, computer models. And this stuff is intricate enough that I need to build a model in order to bring together the moral reasoning aspect and the empirical aspect. And what we're going to do is construct some counterfactuals where we say, what would the world look like, more precisely, what would Canadian health distributions look like if this or that unjust source of health inequality could somehow be removed? Now, the conventional observation, to start with, when we talk about health, there's myriad ways that people talk about it. Often it's in terms of health status, or maybe in terms of mortality rates, and it's broken down by socioeconomic status very often, income, education, and sometimes gender, race, geography, small area data. Essentially cross-sectional, and they treat health status while living separately from mortality. Ideally we would want to look at the whole life course, another theme that was certainly developed and built on in the Pop Health program. So we're going to bring together health status and mortality. I'll tell you in a second how we do that, and we're going to look at full life cycles, not just age groups. So there's various definitions of inequalities. I used to hate this. Julian Legrand, would plot a survival curve and say, well, if the survival curve was rectangular, then there would be zero health inequality, and I'm going to compute the Jeannie coefficient. Actually, if you look not at the survival curve, but the distribution, I'm waving my hands for, the distribution of ages at death, the closer that was to a single spike, the less health inequality there will be. But I'm going to come back and actually use that approach. I thought it was terrible because it completely ignored the socioeconomic aspect. Meanwhile, there's the World Bank had something, I think it's Eddie Van Dorslayer and others. Equity has long been considered an important goal in the health sector, yet inequalities. Why did I put that quote in? Because they seem to be equating equity and inequality. But the whole idea of talking about just and unjust health inequalities is some may be inequitable and others may not be. And then there's other groups, chunks in the literature that talk about social groups, which means a categorical, if you're at all mathematical, rather than a continuous variable as the key thing that you're going to use in looking at that. Beware of the mean. Well-intentioned pop health interventions that improve population health may in fact increase inequality, and perhaps the most famous example is efforts to reduce smoking rates. On average, reduced smoking rates, but did more so for those who were better educated because they were more receptive to the educational messages, and they were able to act on it. Something similar, I gather, in the case of asthma management programs, especially for children. So there are various definitions of unjust health inequalities extant in the moral philosophy literature. And the key one here, I've quoted Asada and Hausman, is when there are factors related to either unequal opportunities or things that are amenable to policy interventions. Angus Deaton, recent Nobel Prize winner, and a guy with whom I tend to disagree, said health inequalities are those that are plausibly attributed to freely undertaken personal choices. Well, I could be persuaded in the case of skydiving. In the case of smoking, not really, because as Bob was saying earlier this morning, smoking isn't something that's freely chosen. It's heavily conditioned by your social milieu, your peer groups and all that. And the example of a doctor in Médecins Sans Frontières who risks his or her life to go help Ebola patients, that's a freely chosen action, but I don't think we would want to say that if they themselves die of Ebola, that was a just health inequality. I think we would say the opposite. And finally, Deaton also points out what really matters is overall well-being, and health is just one component. And presumably, since Angus is a great economist, if you gave them enough money, they would be willing to say, I'm equally well off, notwithstanding that I'm paraplegic. And that raises a whole bunch of complexities that I'm going to leave out. So the main idea here of this analysis is to create a simulation model called health paths, where we're going to look at health-adjusted life expectancy, which is the regular life expectancy, which is a ubiquitous but lousy measure of population health because it treats people as either alive when they get a 1 for a person year of life, or dead when they get a 0. And I like to think instead of, there's some years when you're sort of half yucky or a little bit more yucky, so we'll give you a 0.8 or a 0.7 for that year of life. So health-adjusted life expectancy adds that weighting. It's not without controversy, but better than life expectancy. I'm taking a dig at Chris Murray and the global burden of disease, but we'll talk about that later if you want. We want to include heterogeneities in the population. That's absolutely fundamental if you're going to talk about inequalities. And I'm going to focus on functional health, in particular as measured by the McMaster Health Utility Index. And I've heard Bob over many years mention the idea of disease as epiphenomena. So this analysis takes that to heart and says we're going to jump right over from risk factors or socioeconomic background or upstream factors to functional health status as measured by the HUI. And another thing here is a mode of analysis, and I think I can tell you from experience it's not a popular mode of analysis from the point of view of CIHR because they've never funded it for want of trying. But what we're doing here is saying we don't want to just do some statistical analysis where the result is 3 or 4 tables in a journal article. We're going to do a statistical analysis, that doesn't care how many variables. In fact, we have millions of coefficients in the statistical results, and we're not doing them to publish. The human brain could never absorb them. We're going to do them so we can plug them into a simulation model and generate results which are cognitively accessible, like what happens to health-adjusted life expectancy. So I'll call it extreme statistical estimation combined with microsimulation. So we're using the National Population Health Survey. We're going to look at co-evolving individual health-related factors. I'll show them to you in a minute. We're going to use counterfactual. So for those who aren't fond of the Greek alphabet, there's a delta HALE, which is the change in health-adjusted life expectancy, and say, what are the determinants of that? And when you just stop and think for me, when I started into this area, I said, well, really what we're talking about is a dependent variable that's this complicated object, a multivariate distribution or a gradient. There's no way that conventional statistical methods can handle that. So we need to think outside the box. I also used to spend a lot of time worrying about Jeannie coefficients versus Tile-Bernoulli measures and things like that, and a pox on all that stuff. I'm just going to use a visual, graphical way of displaying inequality. And let's carry on. So these are the variables that are included in the analysis. There are a lot more in the National Population Health Survey, but this is enough. The first 8 on the upper left are the 8 components of the McMaster Health Utility Index, and then income, leisure time, daily, BMI, sense of mastery, sense of coherence, Antonovsky. We put that on the NPHS at the beginning before 94 as a kind of a flyer to see if it made any difference. So anyway, now here's a kind of a graphic of the data. So the NPHS has data every 2 years. And to start, we don't want to impose too many restrictions, so the simple assumption is everything affects everything else. And the estimation process goes, okay, let's take 2 years lagged at a time and estimate that, and then that, and then that. And wow, so we've got some results. And then step 2 is we're going to write a simulation model that takes as input all the coefficients of those relationships and says, okay, let's snip, for example, the impact of socioeconomic status on health and everything else, and say, what's the result? And then we'll snip again and say, what's the result? Snip again, what's the result? Snip, result. And just a footnote that the estimation had to be in discrete time, but the model is actually in continuous time. And here is a first set of results. This time what we've done is knock out each one of the 8 Health Utility Index components one at a time. The upper 2 graphs, this is going to be hard to read, I guess, is life expectancy for women. Which way is it? Men on the left and women on the right. And different colored dot. And the bottom 2 are health-adjusted life expectancy. And I want to draw your attention to pain in terms of life expectancy has essentially no effect. But when you look at health-adjusted, I've got it wrong, so it's health-adjusted on the right, life expectancy on the left, has a dramatic effect. Was it 4 years or so there? By the way, there's many dots there because we did a good statistical thing, which is do replicates. If we look at cognition, again, huge discrepancy between what happens on the life expectancy side on the left for men and women and what happens on the right-hand side for health-adjusted. So pain is something that's not fatal. We rely far too much in our statistics on mortality data and not enough on health status, or better yet, putting the two together. So pain, especially for women, and cognition, especially for men, are the most discrepant between life expectancy and health. I haven't gotten to inequality yet, so I have to go a little, got 7 minutes. So next I want to move to the bigger enchilada here. So we've used body mass index, smoking, whether or not you're in a family or living alone, and your employment status directly. But for the other things, we've sort of grouped the variables in order to keep the graph from not being too difficult to look at. So SES, basically a combination of education and income, physical function. Mental condition includes both the sense of coherence, sense of mastery, and the emotion and cognition variables from the HUY, sensory, vision, hearing, speech, and pain. And here are the results of knocking out or knocking in. We've all heard about knockout genes, so this is kind of the social epidemiology analog, except in the case of things like socioeconomic. Well, let's start with what goes first here. So physical function, in this case I've combined men and women and shown life expectancy on the left side and health-adjusted life expectancy on the right. And physical function had the biggest impact on life expectancy, a bit over 2 years, if you see that little oval, and more or less the same when we get over to the right-hand side on Hale, but it moves from most important, those little ovals are centered on the median, to third most important. Mental conditions, which includes cognition and the sense of coherence, is highly discrepant, not much effect on if you knock it out, or in this case, knock it up. Say we'll put everybody in the best possible situation to, 6 years over there, 5 years? Sensory factors, and underneath that, pain is really important, is again shows major discrepancies here, puts it in the top of the league table of health burdens. BMI, my goodness, nothing. And I'm sorry, folks, there's an awful lot of hype about the obesity epidemic. The next slide will say a little about that. What we did here is say, what if everybody had a BMI of 27? Well, you're better off, actually, on average, or looks like it. Smoking, there's about a year of life expectancy and a bit under a year of health-adjusted life expectancy. Socioeconomic status is a couple years, twice as big as smoking. So in some, mental condition and sensory functions are the most discrepant. BMI equals 27 is protective, SES twice. So why do I felt really nervous at first about trashing BMI as a risk, as a public health panic issue. But for those of you who've seen I think it's Catherine Flagle's stuff in JAMA, and most recently just this idea, these guys, Tomiyama et al., they went through NHANES, and where they had really detailed data, and they found I would never put 7 digits or 8 digits of significance here from a sample, but whatever, it looks impressive. 74 million Americans are misclassified as being unhealthy when you use BMI instead of more sophisticated measures. Now, the crucial bit is, how do we think about health inequalities? And I had the pleasure, or whatever, the tension of sitting in a room at WHO with Chris Murray and Michael Marmot and a couple other people at the same time while they argued about how to measure health inequalities. Chris was on the side of univariate and Michael was on the side of bivariate, what I'll call bivariate. And so I was induced to write a paper with Jeff some years ago, and Yukiko Asada more recently has picked up on the importance of making a distinction and being clear what kind of health inequality we're talking about. So let me just jump ahead. Here's an example of bivariate health inequality. So along the horizontal axis is income deciles. The vertical axis are these bars for men and then the extra amount for female. This is health-adjusted life expectancy, not just life expectancy. There's clearly a gradient. And if there was zero male bivariate health inequality, all of the bars would be as high as the dashed line. A different way to think about it, as I was mentioning earlier on with Julian Legrand type approach, is say, well, we've got this survival curve, and for convenience, I'm going to rotate it 90 degrees counterclockwise and say, well, in that case, if we had zero univariate health inequality, the line would look like the dashed line that I've added. And please ignore the little tail that is sticking up at the top right. Just couldn't draw it all the way. So that if we're comparing the curvy line with the straight dotted line, in this case, health inequality has declined because there's been a greater increase in life length among those at the left part of the horizontal axis, i.e. with yuckier health, shorter life expectancy, compared to those at the top. So zero univariate health inequality is defined as zero variance and either in life length, if that's what we're measuring, or health-adjusted life lengths. Here are some results from the health path simulation models. You take all those regressions that Jeff did with the NPHS and you put them in the simulation model, and we see a bunch of curves, and think of them as rotated survival curves, 90 degrees counterclockwise. The dashed lines are life lengths and the solid lines are health-adjusted life lengths, and because we're doing replicates, you have the median and the 25th and 75th quartiles, or the quartiles there. And I showed this once with Richard Pito in the room, and he was outraged that we had women living to 110 or 120. But what is important, he said, your stuff's garbage. But the point is that this is something that takes account of both the sampling variability of the NPHS and specification, which I don't need to go into right now and don't have time to. So, there's a lot of variation in there, so it's not unreasonable to see such high numbers. Now, the crucial thing is how do we judge inequality? I said I was going to use graphics rather than indices. So there's an equalizing change. Line slopes down to the right, disequalizing change up to the right. And here's what happens if we eliminate smoking. So it's mildly equalizing for men in terms of life length. It's a bit more equalizing for men if we look at health-adjusted life length, although the numbers aren't huge. For females, it's actually disequalizing in terms of life length. What's the intuition behind that? Well, women who are going to die young, or according to the NPHS data, are less likely to be smokers. The women who are going to benefit the most in terms of health from the elimination of smoking are around the third decile in terms of health-adjusted, in this case, life length or health-adjusted life length. So that just summarizes it, and I'm almost out of time here. Socioeconomic status, there's a bit of a counterintuitive result here. So if we put everybody throughout life in the top income decile and the top education group of university graduates, it's mildly disequalizing for both men and women in terms of life lengths, although it's a big upward movement, a couple of years. If we look at health-adjusted life length, it actually seems quite disequalizing for the bottom half and mildly equalizing in the top couple of deciles of health-adjusted life length. The last one I'm going to talk about is pain. Any guesses about whether eliminating pain would be equalizing or disequalizing? How many think it'll be equalizing? That was my intuition too. But it isn't. It's dramatically disequalizing. Actually, it's small in terms of life length, but it's large for men in terms of health-adjusted life length, and it's very large for females in terms of health-adjusted life length. If we were able to eliminate pain, and you believe all the data and analysis that precedes all this, this is the result you get. The intuition is that those people, particularly women who have the yuckiest lives, are suffering from other things, mobility impairments, cognitive impairments, sensory impairments, and the people who are primarily suffering from pain are in the upper half of the health-adjusted life length distribution. Last slide. So I focused on the full life cycle of health-adjusted life expectancy as the bottom line indicator, something I've been pushing for many years. We really need more than piecemeal or cottage industry epidemiology to get at these things. And I guess if I make another gripe, the granting councils aren't willing to invest the kind of money in the teams and groups that are needed to do this kind of analysis. The technique of production isn't well understood. Assessing the justness of health inequalities entails using univariate rather than bivariate if we want to be able to disentangle or take apart the sources of inequality in order to talk about whether it's just or unjust. And I've just taken you through the surprising results to me. Some were at first too, and possibly counterintuitive. Thank you very much.
Thank you very much, Michael. I did a micro simulation of whether or not you could finish that presentation on time, and you did finish within the margin of error, so thank you. So with that, I will turn it over to John, and we'll see how he does.
Thank you, Chris. Well, good afternoon. So I didn't bring my kilt, because I'm not Scottish, as you know. And we have a rule in our family, which is no kilt wearing unless you take 5 years of Scottish country dance training not one night a week. So my wife and I have done that. So at Scottish country dance balls, I do wear the Anderson family kilt because there is no Frank family kilt. I'm just going to answer a question that Chris thought up, which is a great question because it's one we are constantly avoiding addressing, which is everybody in the field of inequalities in health, and I'm surrounded by them in the UK, but in particular in Scotland. There's dozens of people who've spent their lives studying health inequalities by social class. It's quite amazing. And even in others across the channel, particularly in Holland. All of those people tend to agree that deliberate policies that have been tried to reduce inequalities by socioeconomic status have generally failed. But there's not much empirical evidence on this. So I think it's an impression. In fact, if you asked me out of the dozens of health outcomes that I've looked at by social class in Scotland over the last 15 years when we have data, yearly data, only one has come down. Only one socioeconomic gap has come down. And that was the result of a legislated change, the Stop Smoking in Public Places legislation of 2006. 2 years before I arrived, so I had nothing to do with it. And it brought down one health outcome, only slightly, the gap between the rates of prematurity in the poorest and the most wealthy and educated women at birth. And that is, we think, related to the extraordinary exposure of Scots before the law to secondhand smoke. And to give you an idea of that, when I first got there, people across the road from us who'd lived there all their lives. One night we were going out, we said we're going to the movies, and they said, oh, well, you're lucky you weren't here a few years ago before the new law. I said, oh, it's pretty hard to breathe in there, was it? And they said, oh, no, you just couldn't see the screen. So this means that there's a tremendous lifetime exposure to secondhand smoke for women, and the poorer you were, the more likely you'd be to spend your only social night out at the pub. And in the pub, you couldn't see the bar. You had to go right up to it and feel your way. So there are some hypotheses on this question. I'm just going to throw up 4. These are not exhaustive. I just kind of thought these up on the bus. First of all, there's a whole suite of initiatives that have been tried in England that I'll give you the summary of. And they were called area-based initiatives. And the idea was you'd rank order all of the local council areas in England, and you'd choose the 10% poorest. And then you put some money in there and skilled community development people and look for remediable health outcomes and try to help the local economy and give people a good feeling about themselves. And as we'll see, that didn't work. And I think the bottom line is, if you've been on a UK housing estate and had a walk around, preferably with someone big, pretty big, not on a Saturday night, you would not believe for a moment that you could turn it around with stuff like that. Second hypothesis, and Clyde would love this one. Too soon to tell, chew and lie on the French Revolution. Too soon to tell. It would take at least a human generation because of the life course effects of early years. And of course, Bob and Clyde and I on our rented house Lanai in Honolulu wrote that chapter for why are some people healthy and others not in 1991. And that's where I first learned something I'd never appreciated before, and that was Bob said one day when we were sitting writing over a piece of screen there, I don't know what it was, some horrible Commodore or something, weighed about 50 pounds. And we were writing a little bit of a chapter, and I wrote something about reducing mortality, preventing mortality. And Bob said, well, that's a fallacy. And being an epidemiologist, it had never occurred to me. And he said, prevention is not on offer, only postponement. And the chapter was all the better for it, I must say. So, so the third hypothesis is, basically the radical socialist hypothesis, which is it's all tinkering, with the deck chairs on the Titanic. We have to turn around capitalism, and you've heard that one a lot of times. So I'll speak briefly to that one, not too much, because after all, it's not going that way in the UK. Have you watched David Cameron lately? Whew, it's a piece of work. The only thing that's different between David Cameron and Stephen Harper is that Stephen Harper had terrible communication skills. That's the only difference. H4, too inconsistent. I love this one because I think Ted Marmer taught me this. This has to do with interest-group politics, but also to do with the tremendous octopus nature of modern government, which is very difficult to align government. And so often the right hand's trying to bring down something that would be good for equity, and the other left hand is taken away. And I'll give you the example from the UK. So moving quickly on from there. So Scotland attracted me not just because of the fabulous weather, which you'll be familiar with, or the terrific snack food. Either of those was not enough to attract me there. It was really because of the tremendous health inequalities by social class. So without going into a lot of graphs and details, over the last 30 years, there's been a steady rise of inequalities as indicated by mortality. And we know that's a very imperfect measure, but it's well measured. In teens and young adults. And these have actually been due to what are called, so rather euphemistically, external causes, which are drugs, alcohol, violence, and self-harm. And these are conditions, if you stop and ask yourself, what are these? These are due to local culture, belonging to a gang, living in a poor neighborhood, drinking in the wrong pub, wearing the wrong football colors. Whoa. Yeah, you think that's not enough to get you killed. You're wrong. Conditions related to mental health, but strongly influenced by local culture in the hood. And this epidemic of deaths very predominantly in the lower social classes began in the 80s in young men and then spread to young women and became almost as large in young women a decade later. So that is one of the factors that's driven this current status, which is that by comparative analyses that we've done and funded as well, the Scottish health inequalities, if you use the same metric, are the steepest in Western Europe, and they're steeper than most Eastern European inequalities. And it's been going on for centuries. And if you know the history of the clearances, of the crofters, you will know that people came to the cities, or they came to Canada, or they came to the States with nothing, and they could get by crofting because crofting didn't require a great deal more than a strong back. And you made your living in a subsistence way, and the landlord took the excess. But when you were kicked off and had to find work in the cities or in the colonies, unless you got a good piece of land when you got to the Ottawa Valley, for example, you were never going to do very well. So that it's not a new phenomenon. It just takes a different shape now. That's my own view. So that's the kind of bottom line. That's a quick. Now, just to give you a sense of what this looks like graphically, this is the decade. It's the most recent published data, but we have more recent data. It doesn't change anything of life expectancy. So I'm sorry it's not healthy life expectancy. I agree with Michael's comment that that's a much better measure, and those are really steep. But this is the top and bottom decile of what? What's the socioeconomic status measure? Well, the Scots have got this all sorted. They use a measure called the Scottish Index of Multiple Deprivation, which is various census variables plus more recently updated variables, including the most recent unemployment rates, which are, of course, based on a large telephone survey, as you know. And those are then put into an index, a basket, which has been developed for various psychometric type properties over time. And they rank 6,505 Scottish data zones by that index of multiple deprivation. Since there are only 5 million people in Scotland, those are quite fine-grained geographic entities, and they're contiguous with natural communities. So if there's a housing estate, the data zone obeys the boundaries of the housing estate rather than gerrymander across it and create misleading sense of real community social class. So that's the quintiles. These are quintiles. And what you see, women at the top, men at the bottom, is no reduction in those gaps over the decade 2000 up to 2009, 10. Just amazingly flat gap over time. And the actual size of the gap is staggering. You can see that from the graph. So that's what's going on there. Now, at this point, you should be saying, oh, I wonder what happened to the last graph like that for Canada. You can forget the States, Ted. You know, they don't do these, right? They just do. Health Inequality Report, I read one last year, came out from the National Center for Health Statistics, Health Inequalities, 450 pages, leaf through it, not one graph or table on any social class variable. Tremendous, hundreds of pages on race and ethnicity. Hundreds of pages. So, you know, that's how the country's culture sees it. That's how they see it. But in Canada, Michael may have better information, but the last guy to do these analyses regularly was Russell Wilkins. And he retired, and I phoned him a few years ago. I said, Russell, StatsGan, I said, I know you retired. Who's doing this now? And in the phone, I could hear a long pause, and he said, nobody. He said, they didn't replace me. So maybe that's not true, but I challenge you to find me any routinely collected data in Canada on how we're doing on health inequalities by any measure of social class at all. I haven't found any. You know, I pick up stuff by new agencies in Ontario, and it's like stupid stuff like, you know, self-reported pap smear coverage. There's a really bad indicator. You know, like, come on, folks, we pay for those smears. Couldn't we actually get some kind of indication of what the true coverage rate differential was between rich and poor women? You know, like, what is that about? So people in Manitoba, they're laughing because Ontario's been doing this since they started. But they actually collect data from the payments, so they know what the immunization coverage is, what the preventive service coverage is. But in Ontario, it's still self-report. Self-report. Thank you very much. So, you know, don't get me started. So the first hypothesis, I know you wonder if I'm ever going to get back to those, but the first hypothesis was about place and about community, and particularly about the problem of trying to intervene on high-risk communities, right? The poorest of the poor. And just to give you a sense of the characterization of poverty, of deprivation in Scotland, if you graph on the left side, this is an old graph, but it hasn't changed. You graph a whole bunch of European countries, and you put this is men's mortality age up, so it's premature, up to age 64 in 1 year for all of Scotland. And it's all-cause mortality, so it's a good general indicator. And what you've got on the left side of that graph is you've got the countries, a whole bunch of countries in Europe, and so Scotland's right up near the top. I think it might be Lithuania, a little higher than that or something like that. And then on the right, you've got the 32 local councils of Scotland. And you'll notice that their age-standardized mortality for men is like, whoa, goes way up there, and all 8 outlying councils are in Greater Glasgow. So the mean of Scotland is not driven up by most of Scotland. No. It's driven up by everything that starts to be around you on the road when you drive 30 minutes west from Edinburgh. So that's kind of interesting. So we've done a little bit of work to explore this. And one thing we wanted to do was to try and understand whether something that social epidemiologists are a little crazed about, maybe overly crazed about, which is they worry that when you give people a social class variable assigned to them by an ecological strategy, you give them the mean of some, say, basket of inequality indicators that's the mean for their neighborhood, that you're going to misclassify people in there. You know, what about people who've got gentrified houses and now live in Cabbagetown? Or, you know, they're worried about that. Well, that's a peculiarly North American way of thinking of the problem because in your average Scottish housing you take, there's no gentrified houses, folks. There's no gentrified houses, not going to be any anytime soon. So the truth of the matter is that the whole worry about misclassifying people by using area-based SES is probably slightly misplaced. But to try and show that, we ran some analyses using a database with individual-level SES. In this case, we chose completed education, as well as all of the data zones that people live in. And that data set is the Scottish longitudinal study with 250,000 people, and that's a 5% sample of the Scottish survey with tremendous linkage to other data sets. Without getting into detail, we just did that thing at the bottom. We compared the mortality difference between the top and the bottom using people's individually assigned education and then the data zones according to what the fraction of people in the data zone was that had higher education or no higher education, something they call qualifications. And the results were pretty astonishing. You can ignore the left. That's the geographic variation in Scotland. On the right, you see that if you use the individual marker, you get this relative risk of mortality for 50-year-old men. This is over 6 or 7 years of follow-up in the Scottish longitudinal study. You get a relative risk of about 2. But if you use all of the variables that contribute to poverty as it is concentrated in the housing estate versus wealthy, leafy Newtown or in Edinburgh or Bear's Den where the wealthy live in Glasgow, you get a relative risk of 8 or 9. Because misclassification is completely trivial compared to the multiple aspects of poverty that are concentrated in a Scottish housing estate. So, last point on this. The most thoughtful person on health inequalities by social class in Europe, Johann Machenbach of Erasmus University in Rotterdam, and a good colleague, did a look at the actual policies that were put in place to tackle the problems of the poorest areas, which the erstwhile New Labour government termed health action zones. It's terrific how they pick these topic titles, aren't they? You know? Health action zones. And his summary is health action zones could be loosely evaluated in this study he was part of, but the authors concluded that these made little impact in terms of measurable improvements in health outcomes during their short lifespan. So partly not enough prolonged effort and partly pissing in the ocean. You know, what are you going to do in there? And my comment is, if you weren't going to change their housing and change the selection factors that put people in there, what were you thinking? Enough said. H2, second hypothesis, too soon to tell. This is the one I think Clyde feels most strongly about in his BMJ article in 2010. Get them while they're young really was about that strategy. And so that's fine. You could say that we have not tried for long enough to have made the change. Too many people are affected by early life. But if that were true, then we would expect to see at least some diminution of early adulthood or mid-adulthood health inequalities by social class because we've had declining gaps in infant mortality for the last 50 years in the UK between the top and bottom social class in absolute terms. And so that's a marker of the quality of infant life and care. So you'd think there'd be something we'd see something. So I picked the most common health outcome that's epidemic level and therefore easily measurable in the UK, which is obesity rates. Just to show you how bad things are. If you take obesity rates in 14 to 17-year-old girls and you put Scotland at the top, light blue is obesity, dark blue is overweight and obesity. Scotland and England are so far out in front. That's a bad choice of term, I realize. But and if you go to Glasgow, you'll see a phenomenon whereby working class girls who are significantly overweight in terms of what they call the centripetal weight around the middle, are wearing their shorts, their jeans low and their top short to show it. It's called their muffin top. So culture is adapting to trying to make the case that it's attractive. Now, you can think about that what you like, but I don't find it so. And I find particularly the reproductive consequences which are beginning to hit the care system in Scotland of being overweight when you're 20, 25, or 30 are quite scary. Every reproductive outcome is worse, every single one, at significant obesity levels. Now, I'm going to run out of time, so I just want to show you this. There's the gradients by education in obesity in the UK. I guess it's England probably, over 20 years, 1991, 2011. No decrement in the gradient whatsoever, none. And you could say, well, that's because the nature of the obesity pandemic and blah, blah, blah. You know, it's still rolling out amongst children and young people at a greater rate in the lower socioeconomic groups, although it's saturated in the middle. The reason we don't get any higher than a certain rate in midlife is that everybody who doesn't have strong personal protective habits against the obesogenic environment is already overweight. So by the time you're 50, you've got all your new cases. So, you know, hardly anybody becomes significantly overweight after age 50, 55. Hardly anybody. So basically, we have a phrase for it in epidemiology, in infectious disease epidemiology. We call it exhaustion of susceptibles. Once you're at what Scotland is, which is 5/8 of the entire adult population is obese or overweight, done only by the Americans. Congratulations, Ted. You can't get the rest of them. They're not susceptible. Okay, so I'm running really short. So my wife, because she's the chairman of the board of the La Leche League, Great Britain, a charity that works with women to support breastfeeding, has done that for nearly 30 years, she would say, well, there's a bunch of other stuff going on. This is a breastfeeding rate graph over a decade of time in Scotland by, again, Scottish Index of Multiple Deprivation. Looks like a ladder. It hasn't changed a bit. It's not only the lowest overall rate for exclusive breastfeeding, this is one marker. 6 to 8 weeks of age of the baby. But the gap between the rich and the poor is like unbelievable, and it is almost impossible to bring down by normal counseling measures. A massive culture change would have to happen. It would also help if doctors knew something about it and cared. I'm going to skip this because I'm going to get myself. So one of the people that influenced us in the population health program was Doug Wilms. And this is Doug's graph from his doctoral thesis in Edinburgh. Was published many years later, but the data are from 94, roughly. He pulled it together. And we called it the fan graph. It's in Clyde's books and writings. And it's basically a graph of the parents' final educational attainment on the x-axis versus the y-axis shows their measured performance on standardized learning tests across these countries. This happens to be literacy, but the math looks the same. And what it shows is, it's called a fan because if you're a twinkle waiting to jump down from the sky to be born, and you're worried about landing in a poor house or a rich house, it doesn't matter if you're over Sweden. It hardly matters if you're over Netherlands. But if you jump down into the wrong house over an Anglophone country in northwestern Europe or North America or New Zealand, you're in trouble in a poor house because you'll never get the educational attainment of the kid who jumped down into an educated house. And that has not changed. That curve looks almost the same in the most recent data for Scotland and England. So what's my point? My point is the reason we may not be seeing any changes in midlife is not only because we haven't done all the health things right, like breastfeeding in early life across the social class gap, but we are actually not even giving people a fair shot at school because we don't have universal high-quality pre-primary. When kids hit school, from bottom end of Scottish society, what they've heard from their parents say to them in many cases on the bus is, when kids are a little upset over something's happened, they maybe they can't get the candy out of their mouth, and they start to cry, and the parent says, "What's the matter with you then?" That is not making fun of people for being poor and having a bad attitude towards parenting. It's because the long reach of Calvinism controls their response to their children, and they don't know any other response. So that's a bad way to grow up. And if you're Scottish and you're upset by anything I've said, please come and speak to me afterwards, because I do love the country, and I wouldn't give it up. So I'm going to finish with the last one, because we don't have time to go through all this. I just want to, oh yeah, by the way, if you think this is a radical idea, the extraordinarily radical socialist organization Ofsted, which is the inspection body for the UK, Inspection, School Inspectors, has recently published